Hello and welcome to our presentation of Geriatrics in Jeopardy. Today we will be taking a look into the healthcare of our fastest growing age demographic. First off, you may be wondering who I am. My name is Mark Garofoli, and for a quick little bit about me, my pharmacy career technically started out at a 7th grade spelling bee, where I lost because I spelled relief as R-O-L-A-I-D-S. And yes, that really happened. After attending the University of Pittsburgh, came a time of climbing the CVS corporate ladder, which actually started as pharmacy technician, and then jumping off the ladder to land as a clinical MTM pharmacist, which is my current position. But enough about me, because we really do have a lot of great information to cover here today. Our learning objectives include the ability to recognize sociological and psychological differences among generations, to describe the physiological changes of the geriatric population, to outline the medications that should be avoided in the geriatric population and their respective alternatives, and finally, to identify geriatric certifications and references. Most people agree that our general geriatric population, or those 65 years of age and older, is growing in numbers. But let's first take a look at the actual numbers of that progression. 2011 is the year in reference because of the most recent national census. About 3 million people celebrated their 65th birthday in 2011, and census estimates showed an annual net increase between 2010 and 2011 of about 1 million people 65 and over when considering those turning 65 and those passing away over the age of 65. This table shows the past, present, and predicted future of the growing amount of the elderly population. For a specific example, between 1980 and 2010, the Centurion population, that is those aged at least 100 years old, experienced a larger percentage increase than did the total actual overall population. The bottom line here is that the actual population numbers support the general idea that we're all living longer. Now that we've seen the overall trend of how people are living longer, let's now take a quick look at just how long the oldest people are actually living. In general, take a moment to not only realize how long these people have lived or are living, but also that the oldest person ever is almost double the first year of a geriatric classification, that is to say 65 years old. Beyond helping people live longer lives, as healthcare professionals, we also strive to help people have a high quality of life along the way, and really enjoy life to the fullest. Here are a few examples of people living life to the fullest in their respective quote-unquote past prime years. All in all, the idea here is that one of the secrets to living longer is to continue a high quality of life. There are many stereotypes in the general public as to the elderly population, or even the teenage generation for that matter, but in the end what really matters is knowing what makes each and every person tick per se. Thus, after glancing at these cartoon thoughts, let's take a brief moment to see some of the accepted differences amongst our current living generations. Here we have a breakdown of the generations that we deal with, or are even a part of, as today's healthcare professionals. Please take note of the birth year ranges as well. In the GI or silent generation, the key reward of what they're looking for is the satisfaction of a job well done. Whereas the baby boomers tended to grow up in nuclear families, but do not actually have nuclear families themselves. They are team players, workaholics, they pursue personal gratification, and the key rewards to the baby boomers in general are money, title, and recognition. Also of note is that they do not want to be continually connected. When it comes to Generation X, one of the key rewards for that generation is freedom and time. For millennials, the key reward is that their work actually has meaning. A key aspect of this overall information to keep in mind regards the baby boomer generation, which is now drastically increasing the number of elderly patients. Before jumping into the medications of concern for use in the geriatric or elderly population, first let's take a look at some social issues facing our seniors, and always keep in mind geriatric determination to never give up, as seen here. We will, of course, review these medications more in depth later on, but here we just want to keep in mind that there is a long list of very common medications that can affect something that we all take for granted, such as simply seeing the world and driving within it. One of the most important ideas to keep in mind as healthcare professionals is the concept of putting yourself in one's shoes, or as this side depicts, the eyeballs of others. As our society progresses with technology such as Google Glasses or contacts or whatever else, let's not forget how people are actually seeing along the way. Back when I was a resident assistant or RA in college, an activity we had for our students was to put on beer goggles, which were actual goggles that blurred your vision to the same regard that alcohol would. To say the least, that activity was, dare I say, very eye-opening to many students whom then couldn't even walk a straight line. As this slide hopefully illustrates, these eye conditions could drastically affect the daily activities of those affected, let alone their driving. Yeah, so by now, you're probably Googling beer goggles, and it actually happened. It was like the greatest thing I did as an RA. Well, top 10, maybe not the greatest. Anyways, onward. Keeping those eyesight views in mind, one may find this cartoon funny. However, the idea here is to realize the need for preventing vision-changing side effects in anyone, and especially the elderly population, as more and more are continuing to drive later in life. At first glance, this table might look rather complicated, but it can be best summarized in grouping those drivers aged 16 to 34 as having more traffic deaths than those above the age of 65, while those aged 35 to 64 have less traffic deaths than those above 65. So in essence, we still know that our teenagers really are in the most deadly accidents, sadly. However, baby boomers have less deadly traffic accidents than the current elderly drivers. Another aspect to keep in mind is that although one may end up driving within weeks or even days of a non-deadly traffic accident, other healthcare-related events may take a bit longer to get back in the saddle, as they say. The idea here is twofold. One, to remember how much one's life changes after one of these events, and two, to do our best as healthcare professionals to avoid and prevent these events in the first place. There is a clear and distinct separation of church and state in our government and country. However, when thinking about best taking care of our patients, one should also keep in mind a patient's respective beliefs. I highly recommend to always remember to ask about and respect any patient's beliefs. Another touchy geriatric subject is, of course, intimacy. Here, one can see on one side of the coin, many elderly patients continue to be sexually active, while others have numerous reasons to not be. Another important aspect of geriatric intimacy is the want for companionship, or at the very least, someone to talk to, whether family, friends, or volunteers. Anyone can greatly impact the life of an elderly patient, sometimes more than even a medication such as an antidepressant, by simply spending time with that person. Whether using a service like LegalZoom online or an estate planning lawyer, it is highly recommended for anyone to have their quote-unquote paperwork in line. This paperwork, of course, becomes even more important to have in order for all geriatric patients. The paperwork starts off by including things like living wills, power of attorney, and then we stem into the durable power of attorney, which actually is still valid even if the patient becomes incompetent, and the more specific version of the durable power of attorney for healthcare decisions, which is also valid if the patient becomes incapacitated. Important legal paperwork and issues for geriatric patients are listed here, and the important concept to remember is the reason for having all and not just one or two of them. Here are more important legal issues and paperwork for geriatric patients, thus again showing that the list is long, but all equally important to consider. So the question I pose to you is, do your geriatric patients have this paperwork in order, and have you asked about it? Or, if applicable, do your parents have this paperwork in order? Then, and here's a drastic idea, do you have this paperwork in order for yourself? Now let's get into some geriatric medication considerations. As this table illustrates, just about every elderly patient is on medication, or is a flip of a coin away from being on about a half a dozen medications. Furthermore, on average, elderly women take more medications compared to elderly men, particularly psychoactive or arthritis drugs. Medication use is also greatest among the frail elderly, hospitalized patients, and nursing home residents, where a typical nursing home resident is given 7 to 8 drugs on a regular basis. Speaking of nursing home residents, here are the most common drug interactions occurring in our long-term care centers, which include many very commonly prescribed medications, as you can see here. So we have to ask ourselves, what is causing these drug interactions to happen in the first place? Well, let's face it, as we all age, our bodies change. That's about the simplest way to explain things overall, but let's take a closer look at what these changes are. By the way, these pictures here are to remind us of the basic idea that pharmacodynamics is what the medications do to the body. On the other side of the coin is the obvious opposite of pharmacodynamics, which is, of course, pharmacokinetics, or basically put, what the body does to medications. Here, the grapefruit juice is shown as just a little reminder of the traveling pattern of many seniors, otherwise known as snowbirds, traveling to Florida, Arizona, or some other more comfortable winter climate, and how where a patient resides may change just as their medication concerns may also change along the way. Now let's take a specific look at just what does change in our bodies throughout the years, with specific regard to the age of 65 and beyond. In the cardiovascular system, first off, the heart wall thickens, heart rate decreases, and systolic blood pressure increases. In the pulmonary system, our chest wall thickens, and also the central airways widen, which will naturally decrease pulmonary flow. In the central nervous system, or CNS, sadly, our brain size decreases. There's also serotonin system overall changes. And one thing to note also is that the blood-brain barrier also thins. As we can see here, there's numerous changes within the endocrine system, including and ranging from the idea that our kidney size decreases, our GFR decreases, along with our renin activity decreasing, which will lead to less sodium being retained. Along with that, hormone receptors and glucose tolerance decreases, and overall we also sweat less, thus the body overheats easier. Within the hepatic system, our liver mass also decreases, and the CYP3A4 or liver function enzyme function decreases as well. Basically, our entire immune system function decreases over time, and as you can see, there are numerous changes within the GI tract. And within regard to our overall body, the body water to muscle ratio decreases. At the same time, our body fat increases, and of course, hearing and vision decrease along the way too. All of these anatomical and physiological changes were the underlying factor of consideration for the original gathering of what medications are of greater concern for use in an elderly patient, which naturally leads us to the infamous beers list. No, this is not a listing of the top fermented beverages of all time, although that may also be interesting. It may not be as beneficial for our patient care. The 1991 Beers criteria for potentially inappropriate medication use in older adults, commonly called the Beers list, is a guideline for healthcare professionals to help improve the safety of prescribing medications for older adults. Both the 1997 and 2003 revisions had an overall purpose of classifying medications as 1. Medications that should generally be avoided in persons 65 years or older because of not being as effective or posing a high risk while there was a safer alternative available, and 2. Medications that should not be used in older persons known to have specific medical conditions. I've provided links to each of these specific articles here. Once again, the overall emphasis in medication use in the elderly is to avoid side effects based on our aging bodies. One can think of this as a teeter-totter of balancing the good and the bad, or better yet, simply maximizing the good and avoiding the bad. The 2012 Beers criteria identifying group medications that may be inappropriate for older adults into 3 different categories instead of just 2 as previously revised. The first category includes medications that are potentially inappropriate for older people because of, once again, the higher risk for adverse events, possible limited effectiveness, and also the fact that they're safer alternatives. The second category includes medications that are potentially inappropriate for older people who have certain medical conditions, once again. The third category includes medications to be used in caution with older adults. The addition of this third category is important because it emphasizes that medications need to be tailored to the unique needs of each patient. Updated review criteria in the 2012 update was based on both 1. Quality of evidence, and 2. Strength of evidence. Designations of quality for the 2012 updated beers list included high, moderate, and low, as described here in a little bit more detail. Strength of evidence for the 2012 beers list update also included strong, weak, and insufficient, as also noted here in more detail. All in all, we as healthcare professionals now have an overall guide of what medications or drugs to avoid in the elderly, including those listed here, which we will now review in more detail. For each grouping of medications, I will make note of the quality of evidence and strength of recommendation so that the structure of the 2012 update will be upheld. Most importantly, for each grouping of medications to avoid in the elderly, we will give examples, review the rationale behind the caution, and most importantly, review alternatives to effectively use in practice. A very simple to use pocket guide of this information is available at the website I've provided here. First, we have the group of antihistamines with numerous examples here, with the overall rationale that their clearance is reduced with advanced age and tolerance develops when used as a hypnotic. Basically, these medications fall into the larger group known as the anticholinergics, which all have the risk of side effects including a greater risk of confusion, dry mouth, constipation, vision changes, and so on, and so on. Please keep these couple specific side effects in mind for other drugs to avoid in the elderly. One little note on the side is that the use of diphenhydramine in special situations such as the acute treatment of severe allergic reactions may be appropriate. Other alternative categories include the use of sleep medications or treatments, including sleep hygiene, trazodone, or even the supplement of melatonin. For allergy treatment, the newer generation of antihistamines, which do not affect the crossing over of the blood-brain barrier, those including cetirizine, fexofenadine, loratadine, or even fluticasone nasal spray. And for treatment and prevention of nausea and vomiting, we have ondansetron. And if being used for anxiety, the alternatives including citalopram or sertraline. Couple ideas to note here is that the tricyclic antidepressants, or TCAs, and other anticholinergic medicines will be discussed later, and I also would recommend keeping in mind these listing of the treatment classes and their alternatives along the way as well, as there will be a repeating. When it comes to anti-infectives or antibiotics, the main antibiotic to avoid for use in the elderly is nitrofurantoin because of its potential for toxicity and the fact that there's safer alternatives available. Basically, there's also a lack of efficacy in patients with lower kidney function due to an inadequate drug concentration in the urine. As far as alternatives go, they are always going to be based on local antibiograms and resistance patterns. We certainly want to avoid long-term use of this medication. And alternatives include sulfamethoxazole trimethoprim combination, trimethoprim alone, cephalexin, or ciprofloxacin. The 2012 updated beers list does include some not commonly prescribed medications, but I still wanted to include them along the way as slides just for reference, such as these antithrombotics. The first grouping of cardiovascular drugs to avoid in the elderly include the alpha-1 blockers such as doxazosin, prazosin, and terazosin. The rationale here is that there's a higher risk of orthostatic hypotension, or dizziness, which one could also get in the manner of this picture, and it's not recommended as routine treatment for hypertension. Alternatives include many different types of other blood pressure medicines, which quite honestly could be an entire CE in itself. But in general, the hypertension medicines alternatives include from the new guidelines, which don't really specify which thiazide to use, but explain that chlorthalidone or indapamide have more evidence for improving cardiovascular outcomes than hydrochlorothiazide. Also, for African Americans, I recommend starting with a thiazide or calcium channel blocker, because ACE or ARBs don't lower blood pressure or stroke risk as well when used alone in African Americans, but do work well when added to a thiazide or calcium channel blocker. We recommend starting with 2 first-line medications for a blood pressure that's greater than or equal to 160/100. Also, avoid combining an ACE with an ARB because there's basically no added benefit and a higher risk of hypotension, renal impairment, and hyperkalemia. Another note would be to suggest saving selective beta blockers such as metoprolol or atenolol for patients who need them for other indications such as heart failure or after a heart attack. They just don't seem to work as well as other medications for uncomplicated hypertension. As I mentioned, this entire concept could be an entire seat in itself, but please keep these guidelines in mind for other cardiovascular drugs to avoid in the elderly. The next type of cardiovascular grouping of medicines are the central alpha agonists, with the most commonly prescribed being clonidine. Once again, the rationale here is a risk for side effects including bradycardia, and once again, orthostatic hypotension, and they're not recommended for the routine treatment of hypertension in the elderly. The same idea goes for the recommended alternatives as we just discussed. Numerous antiarrhythmic medications are listed here as those to avoid use in the elderly. Overall, the rationale is that suggests that rate control is better than rhythm control for older adults, along with a long list of side effects and concerns for use of these medicines, especially amiodarone. The recommended alternatives include medications such as metoprolol, verapamil, diltiazem, or even low-dose digoxin 125 micrograms. Overall, one wants to avoid these previously listed medications as first-line treatment for conditions such as atrial fibrillation or AFib. Also, of note, the diltiazem and verapamil or non-dihydropyridine calcium channel blockers are to be avoided for systolic heart failure. This disopyramide information is also not commonly prescribed and put here just for reference, along with this information for dronedarone because it is also not commonly prescribed and here for reference. A very straightforward recommendation involves digoxin because of the rationale that in heart failure, higher dosages are associated with no additional benefit and a higher risk of toxicity and side effects. Basically, one wants to limit the dosage of digoxin to 0.125 milligrams, along with monitoring digoxin serum levels, potassium, magnesium, calcium, and renal function in elderly patients. Immediate release nifedipine also gives a potential for hypotension as side effects, along with a risk of precipitating an MI. Similar alternatives as previously discussed are recommended for this medication. The overall concern for use of spironolactone in the elderly is that one wants to avoid a dosage of greater than 25 milligrams in patients with heart failure or decreased kidney function. Along with limiting the dose, one also wants to monitor the potassium level and renal function of the elderly patient. To segue us into the next grouping of medicines for the central nervous system, we'll start off with anti-Parkinson's medications of benztropine and trihexyphenidyl. Although not commonly prescribed, it is still not recommended for the prevention of extrapyramidal symptoms with antipsychotics, and basically there's more effective agents available for our elderly population. Those alternative medications include carbidopa-levodopa, ropinirole, pramipexole, and amantadine. As previously mentioned, the TCAs, which fall into the category of the central nervous system grouping, are highly anticholinergic, so there's the risk of the side effects as previously discussed. The same alternatives for anxiety and depression and sleep as previously discussed should be used, along with now, if treating neuropathy, one could also consider the use of gabapentin along the way as well. The next grouping of central nervous system medications include the first and second generation antipsychotics, with the overall rationale that there's an increased risk of stroke and mortality in persons with dementia. Basically, the alternatives include the preferred use of haloperidol or risperidone, along with naturally the cognitive therapy and psychological evaluation along the way, and if being used for depression, the typical alternatives as discussed. Thioridazine and mesoridazine are also not commonly prescribed but provided here as reference. Our next grouping of medications to avoid in the elderly in regards to the central nervous system are the barbiturates, highlighted by phenobarbital. The overall rationale here is that there's a high rate of physical dependence, there's a tolerance to the sleep benefits, and a risk of overdosage even at a low dosage. The recommended alternatives include the alternatives we previously discussed for sleep treatment, depression treatment, and vomiting, along with the usual cognitive therapy and psychological evaluation. One of the biggest medication obstacles is the use of benzodiazepines or benzos in the elderly. In practice, I sometimes find it hard to recall a geriatric patient not on one of these medications. Here I've listed the benzos and grouped them by duration and length of action to make things a little bit easier. Overall, for rationale behind these medications is the idea that older adults have an increased sensitivity to benzos and slower metabolism of the long-acting agents. In general, all benzos increase the risk of cognitive impairment, delirium, falls, fractures, and motor vehicle accidents in older adults, which is a great time to think back to our review of an elderly patient's vision and driving. Alternatives to these medications are as previously discussed for anxiety, depression, and sleep treatments. These uncommonly prescribed medications are also provided as reference for information on medications to avoid in the elderly. Our next grouping of CNS medications to avoid in the elderly brings us to the hypnotics. The idea here is that these medications have adverse events similar to those of benzos in the elderly, and there's minimal improvement in sleep latency and duration. Overall, it's recommended to avoid the use of these medications for more than 3 months or 90 days. I'm sure that we could all agree that a good night's rest goes a long way. However, we also have to ask, at what cost? In this instance, the sleep alternatives, as we had discussed earlier, are still applicable, including sleep hygiene, trazodone, or melatonin as a supplement. Our next grouping of medications to avoid in the elderly include the endocrine system agents, starting off with androgens, such as the more commonly used testosterone. The rationale for avoidance here is that there's the potential for cardiac problems, and also it's contraindicated in men with prostate cancer. Overall, one wants to avoid unless indicated for moderate to severe hypogonadism. That leads us to the overall idea for alternatives to basically consider alternative therapies such as hair loss medications, erectile dysfunction medications, and others along the way as well. Our next endocrine system agent is megestrol for the typical uses of depression treatment or weight gain. The rationale here is that there's really a minimal effect on weight, along with the increased risk of thrombotic events and even possibly death in older adults. Thus, the usual alternatives we've discussed for depression treatment, along with alternatives for weight gain including nutritional supplementation and also dronabinol. Here we see that desiccated thyroid is also a medication to typically avoid in the elderly because of the rationale for the concerns on the cardiac effects, and also because very easily there's safer alternatives available. Here, this chart shows the example of the easy conversion between the desiccated thyroid or armour thyroid over to the synthetic thyroid or levothyroxine. If there's one takeaway point here, one could simply try and remember that 1 grain or 60 milligrams of desiccated thyroid is the equivalent of 100 micrograms of levothyroxine. One of the hotter topics per se for treatment within our geriatric population is the avoidance of estrogens, really without regard to whether progesterones are included as well. The rationale here is that there's evidence of carcinogenic potential in both breast and endometrial cancer. There's also a lack of cardioprotective effect and cognitive protection in older women. It's really going back to that teeter-totter of, really getting rid of the bad side of the teeter-totter. Overall recommendation is to avoid oral and the patch version of estrogens. The alternatives include for menopausal symptoms to use citalopram or sertraline, for vaginal dryness to use Premarin, vaginal cream, and for osteoporosis prevention of the bisphosphonates we have alendronate, and also calcium with vitamin D, or even Avista. Another one of the tougher avoidances for medication use in the elderly is the idea of sliding scale insulin. The rationale here is that there's a higher risk of hypoglycemia without a great improvement in the hyperglycemia management, regardless of where the patient is. The recommended alternatives are to use a longer-acting insulin along with an immediate-acting combination. The overall idea here is that flexibility is good, but too much can be bad. We want our geriatric patients with diabetes to have flexibility in their diabetes management, but we also want to have a good foundation of care. Dare I say, we want our cake and eat it too. For general insulin conversion recommendations, typically it's recommended to convert 50% of the total daily insulin to long-acting dosage. For instance, if a patient is using 200 units on average of daily sliding scale, then the dosage for the long-term, for instance, Lantus dose insulin would be 100 units at bedtime. One of the quote-unquote easier changes to recommend for medication use in the elderly involves the long-acting sulfonylureals for diabetes. Examples including glyburide and chlorpropamide, with glyburide probably being the most commonly used. The risk here is very basic of having a side effect of hypoglycemia in older adults, which we certainly want to avoid just as much as an episode of hyperglycemia. The alternatives very simply are glipizide or glimepiride. One thing to note here as well is that glyburide sounds very, very similar to glipizide to the lay person. This concept brings up a great point for dealing with patients who are a little harder of hearing. It is not beneficial to merely speak loud and louder and louder to someone hard of hearing. It is more important to pronunciate your words and speak as deeply as possible. A good comparison of this is basically speaking louder English to a Spanish-only speaking person. It's really just not going to work in the end. Our next grouping of the medications to avoid in the elderly include the gastrointestinal or GI types of medicines. First off, we have the antispasmodics as listed here, with probably some of the more common ingredients being dicyclomine or even hyoscyamine. The rationale here is that once again these are highly anticholinergic, so yet again want to avoid the side effects of these medications. Some recommended alternatives here include the therapy group for constipation, including psyllium, polyethylene glycol, docusate, or even Amitiza. When preventing ulcer, we have omeprazole. For preventing irritable bowel syndrome pain or IBS pain, there's citalopram or sertraline. And of course, for treating diarrhea, there's loperamide. Please keep these alternatives in mind going forward as well. Our next GI type of medication to avoid in the elderly is metoclopramide. Basically here we want to avoid the side effects yet again of what this medication could cause, especially in frail older adults. Here we would be thinking about avoiding the extrapyramidal effects, including tardive dyskinesia. The same type of alternatives that we just discussed would be implied here. Our next GI medication to consider is oral mineral oil. And here the concern is that there's potential for aspiration. And once again, the same typical alternatives that we just discussed would be available for things like constipation. Information on trimethylbenzamide is provided here since it is not commonly prescribed and is here just for reference since it is on the updated beers list. Now we'd like to go over the pain medications to avoid in the elderly. First off, I'd like to point out our picture here that's just a little reminder for compassion in pain management because many geriatric patients simply want to be able to enjoy life. Here first we have meperidine, which the rationale is that it's not really an effective oral analgesic in dosage that are commonly used. It also might negatively affect the kidneys, and there's safer alternatives, such as the grouping for mild to moderate pain for acetaminophen. And then when there's moderate to severe pain, we certainly have hydrocodone or oxycodone. Just a little thought on moderate to severe pain treatment. When recently visiting Italy on a family vacation of a lifetime, a pharmacist there noted that pretty much anything besides over-the-counter NSAIDs is reserved for, as he worded, very, very bad pain. He went on further to say that in the last 2 years, he dispensed 2 or 3 prescriptions for OxyContin. Yes, I said 2 or 3. Just some food for thought there when it comes to pain management. Next up, as far as pain management medicines, we have the oral non-COX selective NSAIDs, with numerous examples as mentioned here, with one note that meloxicam is also included here, even though it's described as a selective COX inhibitor. However, it is to a much lesser degree than a medicine such as Celebrex. The rationale here is that there is an increased risk for GI bleeding and ulcer disease in the high-risk groups, including those over the age of 75 and on these specified medications. The alternatives here for chronic use include Celebrex, also acetaminophen if it's not inflammation, or capsaicin topical cream. One thing to note is that Celebrex actually is not expected to be available in generic form next year, even though its patent was started back in 1998. It's been a while, but just a little update that as far as I know, it's still not coming generic this year or next year. Additional NSAIDs to note include indomethacin and ketorolac, and the reason I separate these from the previous slide is basically that relative to the previous NSAIDs on the last slide, these two have an absolute recommendation of avoid, not just avoiding chronic use. Pentazocine information is provided here because it's not commonly prescribed, but it is still on the updated Beers list. Our final grouping of pain medications to avoid in the elderly include some of the examples of skeletal muscle relaxants, as included here, with the rationale that most muscle relaxants are poorly tolerated by older adults because of the anticholinergic effects, yet again, especially including sedation. The alternatives, or less likely to produce those side effects, include baclofen or tizanidine, as mentioned here. As a side note, I would like to mention I once hurt my back and was actually prescribed one of these, that being the generic Flexeril. I actually took half the dose and couldn't even tell my then fiancé and now wonderful wife my name over the phone. As far as side effects go for this group of medication, I just want to clarify that I'm not even a geriatric patient, so keep that in mind when thinking about the sedation types of side effects for this group of medicines. Now that we've gone over in detail the first category of medications to avoid in the elderly, as per the 2012 update of the Beers list, here's an overview of the second category, basically highlighting medications to avoid in certain medical conditions as per the 2012 updated Beers list. At this point, I would like to just remind everyone of the importance of thinking about how to actually help a geriatric patient change for the better. This is in regards to talking with the patient themselves and also with the patient's provider or multiple providers to really affect change. One of the tried and true methods for really affecting change is motivational interviewing. There are numerous courses and certifications and publications out there on this topic, but all in all, to try and summarize even in just one slide here, the four main concepts within motivational interviewing to help in healthcare here would be to express empathy along the way, develop discrepancy, always rolling with resistance, and certainly to support self-efficacy. I've highlighted a couple of details here of each, but certainly I would recommend looking more into this on your own as well if wanted. Within 1 second of looking at this slide, you're probably wondering what in the world we're going for here. But the overall idea is that there are extremes in any case to drive home the idea that, in the end, we do want to respect the wishes of each of our geriatric patients. When a 100-year-old patient wants to do something that may not be the healthiest for him or her, we most likely will not agree, but do have to respect their wishes to a point, with the reality that we as healthcare professionals must have done something right in the first place to get that patient to the age of 100 while being healthy. Now we could also think about the overall idea of why do Medicare plans pay for change that we're trying to do? The idea here is that a major financial driver for medication plans to help their patient achieve better overall health, other than the obvious, are these things called star ratings. The reason I mention these very important star ratings is that essentially the ratings explain why any Medicare plan would pay for preventing a patient from taking a DAE, or drugs to avoid in the elderly, in the first place. Here we can see that the drugs to avoid in the elderly, or DAE, is a star measure, and it basically reports the percentage of Medicare beneficiaries who have received at least 2 fills of any DAE. Of note, prior to the 2012 update of the Beers list, 20% of enrollees received at least one of these, which is a lot of people. It's only 20%, but that's 20% of millions. That leads us to think of, why do prescribers still utilize DAEs? A couple ideas are that they're still a cheaper alternative to the safer medications. Member satisfaction comes into play because they can't go too far in suggesting a patient not use a medicine that keeps them healthy and happy in their mind. There's also the idea of clinical inertia. Patient took the medicine for 30 years without having a problem, so why in the world would we switch? But it comes down to prevention, even if it hasn't happened in the past. And then finally, just simple lack of awareness sometimes. There's a lot more information on this topic available at www.cms.gov in regards to these star plan ratings. A lot of information to just put down to one slide here. Okay, so getting to the kind of the wrapping end here, is there, the general idea that, I'm going to be a geriatric patient someday, if not already, so where do I go for some more training? Well, first off, there is the CGP, or Certified Geriatric Pharmacist. One might ask, why would you get certified for that? Well, first off, it recognizes those with expertise and knowledge of drug therapy principles for older adults, and provides opportunities to continue furthering one's geriatric knowledge and skill base. For some overall eligibility and fees, eligibility, you have to have been a pharmacist practicing for at least 2 years. Financially wise, a new applicant has a fee of $600. Recertification along the way is $400, plus a $250 5-year maintenance fee. So there's some financial ideas behind this too that one has to take into mind. If wondering how well your geriatric IQ stacks up to the rest of the world, there is availability on their website as provided here for a quick 10-question geriatric IQ. If going further, there's also a candidate handbook which deeply goes into all of the intricacies of getting certified, all the timings and dates and everything for that. There's also a self-assessment practice exam online. Once actually going for the live exam, one could keep in mind that it is simply 150 multiple choice questions, and the application is also provided in the notes section of this slide for you as well too. Exam registration deadlines are usually about 1 month prior to the actual exam date or month. But in essence, overall, if someone is already highly trained and knowledgeable in geriatric pharmaceutical therapy, then he or she could technically pay the fees, sign up, and just take the exam to become certified. However, most of us are much more comfortable with planning, studying, and practicing along the way too. I've also provided some very specific and very good geriatric references, especially in regards to these medications to avoid in the elderly. Some of them including a specific geriatric dosage handbook here, geriatric journal, along with, as we had mentioned, the American Geriatric Society updating the 2012 Beers list. Their information is provided here. And then the Silver Book, which is basically an almanac of thousands of facts and statistics and lots of information in regard to the geriatric population. So I hope that this will provide some information going forward for things to do in the future. Maybe not getting this type of t-shirt along the way, but certainly furthering your knowledge and skill base along the way too.